Thanks, Ann. Thanks for inviting me here. This is my first time to Kingston. The weather is gorgeous. I'm ready to move here. It was thunderstorming and 95 in Dallas when I left, so this is a real treat. And I can't take credit for this title, which I actually like the title. Thank you, Ann. I think drug allergy is something that no matter what field of medicine you're in, it's going to come up. And I think it's something that causes a lot of confusion to our patients, to physicians as well. And even as allergists, we find it a confusing topic. So what I've tried to do with this lecture is come up with some of the common things that I see as a consultant in frequent questions that come up, and do it in a case-based format to make it hopefully a little bit more interesting and engaging. But before we start, I need to tell you where I'm at, and I had to find this map that showed both Kingston and Dallas in the same map. So Dallas is, there we go, right over here, and I had to fly over here, and then, where are you guys? Somewhere here. Oh, there you are. Right there. Most of you have various iconic images of Dallas. This is probably not one of them, but this is our downtown, which looks like a lot of other downtowns. But this is what would come to mind is Cowboy Stadium and the giant mega screen that no one looks at the field anymore. They just look at the screen. Some of you may be more familiar with this icon. But probably most of you, when you think of Dallas, you think of this. And, there's legends about people in Dallas all having big hair or big hats or big belt buckles. I only have two of the three. I'll let you guess which ones those are. Now, anybody know who this is? I didn't expect so. So this is Bruce Beutler. He won the Nobel Prize recently for work on innate immunity. And so this is kind of unfortunate that, in the field of medicine, the real giants are like, who are these people? He's at our institution, and this is, my dean saying, make sure you brag about UT Southwestern. So we've got a bunch of different Nobel laureates at UT Southwestern that we're proud of. This is our medical center. It starts over here on what we call the North Campus and extends all the way down here. And you can see the clear skies here in Dallas. We don't have any pollution at all. All right. So these are my disclosures, which really don't have too much to do with what I'm going to be talking about, other than, as Ann mentioned, I'm on the Joint Task Force for Practice Parameters, and so I'm biased to that publication. So what are we going to be talking about? There's a couple objectives that I wanted to cover. Number one is to think about drug allergy as being a spectrum of different disorders. A lot of times we think of drug allergy as one thing, and it really isn't. It's a lot of different things with multiple different mechanisms. The second thing we're going to be talking about are, when you might think about considering doing some testing and what tests are available. And what do they tell us? What are the limitations of testing and different procedures? And then we're going to drill down into some specifics about certain common allergic scenarios. This is the drug allergy practice parameter, which is available. If you just Google this, you'll find it. You'll find a link. It's freely downloadable. And it's a good reference for if you come across a clinical question about drug allergy, and I just show that for your edification. Well, I want to first talk about some definitions. Drug allergy means different things to different people, and if you ask 10 different allergists, you'll probably get 12 different answers in terms of what does drug allergy mean. So for the parameter, we had to determine how are we going to define this. In the previous version, drug allergy was only for IgE-mediated reactions. And we felt that was probably not the best way to think of allergy, because allergy is more than just IgE. It can encompass a variety of hypersensitivity responses. So this is how we defined it, as an immunologic mediated response to a pharmaceutical and or excipient in a sensitized person. And the concept is it's not all IgE, it can be other things. And one of the reasons we did that is because as allergists, we don't think we should be just talking about, oh, if it's not IgE media, we can't help you. That's not the case. So how do you think about drug allergic reactions? One way is to go back to your days in medical school and the Jelen-Coombs hypersensitivity reactions, which for some of us who've been away from medical school, it's really a distant memory. But there's type 1 IgE, there's type 2 cytotoxic reactions, type 3 immune complex, and type 4 hypersensitivity reactions. And still today, we use this as a way of trying to classify drug reactions. And it works for some, but certainly not all reactions. So there are other different types of reactions. One which you'll commonly see is something called pseudo-allergic reactions, which, as the name implies, looks like allergy, but isn't. And it's not caused by IgE, but it's caused by mast cells that degranulate and look like an IgE-mediated reaction. Common examples would be opiates, vancomycin, things like that. Now, there are other innate immune drug reactions where you get complement activation or bradykinin, so this is another mechanism. And then some of the more severe drug reactions, Stevens-Johnson syndrome, TEN, et cetera, have different mechanisms, and some of which we understand a little bit, and others that we're still trying to unravel. Now, this is a cartoon that shows some of the hypotheses on how drugs become allergens. And the first hypothesis on the left is called the Hampton hypothesis. And the idea is that if you take the prototype drug Hampton, which is penicillin, it's a fairly small molecular weight agent, and the immune system really doesn't recognize it by itself. But if it binds to self-protein, it can then get processed and then presented in the context of this protein Hampton, and now it becomes an immunogen. And this is how a lot of penicillin reactions occur. The next cartoon over is what's called the prohapten, and this is the example would be sulfamethoxazole. So it is not the hapten itself. It gets metabolized to this nitroso compound, and then it gets haptenated and causes the same thing. Not that different, still all antibody mediated. Now here we have a non-hapten reaction. This is the newest one where the drug interacts directly with the T cell receptor. This is called the PI concept, or pharmacologic interaction concept. And this has been proposed to include sulfonamide reactions, other anticonvulsant reactions, and a spectrum of things. This hypothesis doesn't require sensitization, and so you can have first drug reactions with it. So these are some of the hypotheses that are involved with the immunopathology of drug reactions. The latest, and I think probably gives us some hope, is what's going on with pharmacogenomics and drug allergy. And the story for this originally began with the drug carbamazepine. And it was recognized that carbamazepine, which is an anticonvulsant, can cause a Stevens-Johnson syndrome, and everyone knew that. But there's certain ethnic groups that seem to have this occur much more frequently. And one of these was the Han Chinese. And so people then said, well, are genetics involved with it? And what they found was that HLA-B star 1502 had a dramatically higher relative risk of causing Stevens-Johnson syndrome in this specific ethnic group. What's been found now, more recently, is in Northern European, HLA star 3101 appears to be more common for carbamazepine. Abacavir, which is used in HIV, has a different haplotype, HLA star 5701, which causes abacavir hypersensitivity syndrome, a bad drug reaction essentially. And there are now have been studies that have looked at if you screen people ahead of time for this and select them out, you do reduce the risk of reaction. So I know in the United States, the FDA recommends looking at these genotypes for abacavir patients and for carbamazepine if you fit in these ethnic groups. And I think hopefully down the road we'll have more complete lists and be able to avoid some of the severe drug reactions for a lot of different drugs. Now, as you can see, it's a very short list. There's not a lot of things on there, and this is really just only a few drug syndromes, but I think it may be something that in the future we'll have more to offer our patients. All right, so let's talk about the spectrum of cutaneous drug reactions, and I want to start with a case here. This is an 18-year-old who had acne and was started on sulfonamide antibiotic for about 6 weeks, and then started having some cold symptoms, had fever, had some lymph node swelling, saw his pediatrician, was started on azithromycin, really no change in the fever, and 3 days later developed a rash. His face was swollen, so he came into the hospital. Because he had a rash and his face was swollen up, he was in the emergency. They thought, well, this is probably an anaphylactic reaction. He was treated with epinephrine and given a single dose of steroids. And this is what his rash looked like. And you can see it's just kind of what you would refer to as an exanthem, mostly coalescent macules all over his back and some on his extremities. Not terribly specific, but a typical drug rash, if you will. So his initial labs were interesting in that he had striking eosinophilia. A normal eosinophil count is less than 400. His was 4,000. He also had elevated liver function tests. So they thought, well, this is probably just some viral illness. Steroids were stopped, and he was just kind of observed in the hospital. Well, he wasn't getting any better, and in fact, within a few days, his liver function test was worse, his INR was going up, and things were not looking so good. Well, as luck would have it, his mother's spoke with her cousin, and her cousin happens to be a pediatrician in Maryland who's married to an allergist who works at the National Institutes of Health. And so they kind of ran this story by him, and he's like, I think this sounds like a reaction that we call DRESS, and you should put them on steroids. So this was communicated back to the hospital people, and I said, oh, maybe that's a good thing to do. And they started him on steroids, and everything got better. We ended up seeing him, confirmed that this does look like DRESS. He was tapered off on his steroids, and everything got better. So what is DRESS? DRESS stands for drug rash with eosinophilia and systemic symptoms. There's a lot of different terms that have been used for this syndrome over the years, and we may change the term a few years from now and we call something different. We don't really completely understand what causes this reaction, but there are some theories. For the anticonvulsants, it may have to do with poor metabolism and increased toxic metabolites. For some patients, it may have to do with reactivation of human herpes virus 6. Suffice to say, we don't completely understand the immunopathogenesis of this reaction. Now, what's some of the criteria for how you diagnose patients with DRESS is these 3 or more, and this is what's been proposed. If someone is hospitalized, they have acute skin rash, they have fever, lymphadenopathy, involvement of an organ system, and a variety of hematologic abnormalities, including eosinophilia. But you can have this DRESS syndrome, which has eosinophilia in its name, with a normal eosinophil count. And that's why some people don't like the term. So what are other organs that you need to think about? The liver, and this is probably one of the more common causes of significant morbidity and mortality with this drug reaction. Renal dysfunction is also seen in about a third of patients. Some patients may have cardiac or pulmonary involvement, but that's less common. Now, what's unique about DRESS as composed to other drug reactions is several things. Number one is it takes a while for it to occur. So usually the patient is on the drug for several weeks or a month before they have the reaction. Because of that, it's one of the medications that is not thought of that, well, you've been on this too long, it couldn't be this. It must have been what you got within the last week. The other thing that's very unique is that when you stop the drug, things don't necessarily get better. In fact, patients may get worse when you stop the drug, and that's very atypical for drug reactions. And then the third thing is how long this lasts. Most drug reactions, within days of discontinuing the drug, everything's better. With this, the symptoms may persist for weeks, or even months and require long-term immunosuppression. So these are some of the unusual aspects of this syndrome. There's a lot of different medications that have been noted to cause this. More recently, what we've been seeing in the States is vancomycin-induced DRESS syndrome. So that's one type of drug reaction. This is the most common cutaneous reaction, which is the drug exanthem. These are oftentimes referred to as maculopapular eruptions. Dermatologists hate that terminology. But it's these fine, discrete macules or papules that typically start in the trunk, spread in a symmetric fashion to the extremities, and are typically pruritic. Now, what can be confusing is how these evolve. So this is, on the left-hand side, is what an acute exanthem looks like, and then a few days later, you can start to see this peeling. And it looks like a sunburn. Which makes sense. You have this inflammatory reaction of the skin, and you may see some desquamation, and that's normal. You don't need to be alarmed by that. Another common cutaneous reaction is urticaria, which are typically larger lesions, irregularly shaped, and can occur pretty much anywhere in the body. Normally, when we think of urticarial reactions in drug allergy, we think this is IgE-mediated, but it may not be. This is an example of a pseudo-allergic reaction, in this case from aspirin. Fixed drug eruptions are cutaneous reactions that occur at the same site with subsequent exposure. They take the drug and they always get the rash in the same place. And there's a predilection for the genitalia and the breasts in women. You can have a form of cutaneous lupus that's due to drugs. Calcium channel blockers are one of the more common causes of that. This is a less common cause of a drug reaction called acute generalized exanthematous pustulosis, or AGEP. And here you have erythroderma reactions and then very fine pustules. You can have fever and neutrophilia associated with these. Blistering disorders, either flaccid blisters like in pemphigus or tense blisters like in pemphigoid, can also be due to drug reactions. This is a case that we saw a few years ago of a patient who was on vancomycin and got a bullous disease, linear IgA bullous disease, which vancomycin is the most common cause. And they can get bullae in the mouth as well, and this can be confused for Stevens-Johnson syndrome. And then other things like vasculitides, leukocytoclastic vasculitis, drugs being a common cause of it. These are the things that we really worry about are more severe reactions like Stevens-Johnson syndrome. This was when I was on medicine wards a couple years ago. We had a patient who was started on sulfonamide prophylaxis for PCP, and a few weeks later developed this. Again, if you look at his back, garden variety exanthem, but you can see there's involvement within his nose, his lips, some mucosal sites, as well as on his palms, he's getting early desquamation. So if you see early desquamation, that may be more of a serious reaction. And this is one of those wow slides that basically says anything that can happen on the skin might be a drug reaction, including weird things like black hairy tongue. So drug allergy can look a lot of different ways, and I think that's the thing that I'd like you to take home from this. All right, let's go on to another case. This is a case of multiple antibiotic allergy. This is a 77-year-old woman I saw recently who came in for multiple antibiotic allergies. And her current problem is that she's got a Klebsiella pneumoniae urinary tract infection that's resistant to all the antibiotics that she can tolerate. And this has been going on for 3 months, and she's pretty miserable. So her internist was considering putting in a peripheral central line in her PICC line and was going to give her IV aminoglycoside therapy. And she's like, isn't there something better that can be done? And so on her own, she sought an allergist out. So what's her history? So penicillin, in her early 20s, she had some type of reaction to penicillin. She doesn't know what it was, but she doesn't think it was that bad. You know, this is the typical story that you get from a lot of adult patients, is very vague stories. She also has ciprofloxacin and Keflex listed as allergies, and she remembers that sometime 10 years ago she had reactions. One really did sound like she had an urticarial reaction, and the other caused stomach upset, but she didn't remember which was which. Okay? And then she has a sulfonamide antibiotic, Bactrim, listed. She has no idea what happened with that, but it's on her medical record. So she knows she can tolerate certain antibiotics, but unfortunately for her, those aren't going to help her. So at this point, what would we recommend? Have the patient get an EpiPen and then administer penicillin. Any takers here? Believe it or not, I had a patient that was what was recommended. She was an 18-year-old, had RPR positive. She was pregnant. The obstetrician said, and she had a penicillin allergy, said, here's a prescription for an EpiPen and your penicillin. Let me know if you have any problems. And she also said, maybe there's a better way to do this. So strange things happen. Just go ahead and give her the penicillin, refer for penicillin desensitization or something else. So this leads to, what are our management options here? How do we, for diagnostic purposes, for drug allergy, we can do skin testing and we can do graded challenges. So now, do we need to do this for every single drug that someone lists? And the answer is no. First thing we want to figure out is, what's the likelihood they're going to need this drug in the future? If it's very unlikely, let's leave it be. Are there alternatives? We always look for a way out. That's the simplest thing. And do they really need it? Well, maybe you need another consultant to figure out, yes, they absolutely need this particular medication. So for penicillin, we have the best skin test that we have for any drug, and that's penicillin skin testing. And when you do penicillin skin testing, with commercially available reagents, you have a 97% negative predictive value to say you're not allergic to penicillin, which is really good. And it's really the only drug that has excellent validated outcomes. So what we did was we went ahead and skin tested her using the commercial reagents. That got us to a 97% negative predicted value. We wanted to get to 100%, so we just gave her some amoxicillin. She didn't react. We said, okay, you can take penicillin in the future. One down. Now, what about her ciprofloxacin allergy? What we would recommend here, just go ahead and give her ciprofloxacin, cross her fingers. Give her a different quinolone. Should we skin test to the levofloxacin? If it's negative, go ahead and give it. Or should we do something else? So can we skin test for other antibiotics? Sure we can. We can skin test just about anything we can put in your skin. What does it mean? There's the dilemma. The problem is two things. One is when you're skin testing with other medications, you need to know, is this stuff irritating? And we've found this out a lot. You skin test someone, wow, look at this massive reaction. And then you skin test yourself or your nurse or the medical student who's in the office with you, and they have the same reaction. Well, that's an irritant reaction, and it's not valid. So you need to have non-irritating doses. And for a lot of antibiotics that's been published, this was some work from one of our fellows a number of years ago that looked at 15 common antibiotics and published non-irritating doses. Now, if you have a positive reaction that suggests the presence of IgE, but if it's negative, what does that mean? Do we have that 97% confidence like we do with penicillin that they're not allergic? And the answer is no. So having a negative test doesn't really help us. And that's the problem with doing a lot of tests for other drugs. It doesn't give us much answer. If it's negative, we're no better off than without doing the test. So what's perhaps a better way is a graded challenge, which would be really kind of the gold standard for drug allergy. You give them the drug, and do they tolerate it or don't they? Now, graded challenges are referred to by a lot of different terms. Some people refer to it as test dosing. Other people call it a provocation test. I don't like the term provocation because it sounds like you're really trying to provoke a reaction. What we're really not. We don't want to provoke reactions. So I prefer a graded challenge. Now, what is a graded challenge? What we're doing is we're giving incremental doses of the drug over different periods of time to see, do they tolerate the drug? The important thing here is, who are we doing this in? And we're doing it in patients who we don't think are allergic. That's really important. So if you think someone's really allergic and you do a graded dose challenge, guess what's going to happen? you are going to provoke a reaction, and what's the purpose of doing that? But this isn't someone, I don't think they're really allergic, but I'm not confident enough just to say, here, take this. This is the test that you want to do. Now, there's a lot of confusion between a desensitization and a graded challenge. And this is the way that I think you can think of it. What's the question that you have? So if the question is, will this patient tolerate the drug, a graded challenge will answer that question. If, on the other hand, the question is, I've got a patient who's allergic to this drug and they need this drug, then a desensitization is a procedure to allow that allergic patient to tolerate the drug. One is really a therapeutic procedure. One is a diagnostic test. They're really completely different. So how do you do these? Well, some of it depends on the story. So if the history is one of an immediate reaction, they took a drug and within minutes or an hour or so they developed an urticarial response or something that you suggest maybe an IgE-mediated reaction, then you can dose this every 30 to 60 minutes because during that period of time something's going to happen. Where do you start? It depends on the story. The more concerned you are, the lower you can go. The less concerned you are, the higher you can go. There are patients, we give them the full dose. If someone says, I'm allergic to penicillin, what was your story? I got a headache. Here's the penicillin. Let's get this over with. But no one's going to give them that penicillin because on the chart it says penicillin allergy. And oh boy, I don't want to touch that. So those are easy ones to do. Now, for delayed drug reaction, some people, it takes days for them to develop this exanthem. And if we're dosing every 30 to 60 minutes, maybe we're going to miss it. Well, we can dose them every few days or every week. You apply the same principle and you can still answer the question. So getting back to our lady, she had this kind of unclear reaction to the ciprofloxacin. We really don't know what the cross-reactivity is amongst quinolones. And what we ended up doing is doing a graded challenge to the levofloxacin. We started with a quarter tablet and waited an hour and gave her the rest of the medication. She tolerated it very well, and she got relief from her chronic urinary tract infection and was very, very thankful for that. So what did we tell her? We said, levofloxacin, that quinolone's okay, penicillins are okay, and based on her history, macrolides are okay. That's a pretty broad spectrum of things to treat most kind of community-type infections. We're going to avoid sulfonamides, even though she didn't know what the story was. That's not worth looking into. And for now, avoid cephalosporins. So what are the key points of this case? Even patients who have multiple antibiotic allergies can be evaluated. And typically, doing penicillin skin testing and sometimes just one other graded challenge will open up the opportunities enough that you can manage these patients successfully. All right, now another very common question that comes up is, I've got a patient who's allergic to penicillins. Can they take cephalosporins? So here's a 52-year-old who's in need of an orthopedic surgery on her knee. And I know here in Canada it takes 12 to 18 months to get that done. Is that true? No. You're working on that, I understand. So the orthopedic surgeon wishes to treat with a first-generation cephalosporin preoperatively. And her story is that she had some pruritic rash that happened over 10 years ago. So what are the questions here? First question is, which of the following would we recommend? Well, let's just avoid the cephalosporin. Let's just go ahead and give vancomycin. How many people would do that? Nobody. All right, we're very cost conscious. Okay. How many would just give the cephalosporin?
For today.
Few. Okay. One. How many would skin test the penicillin? Okay, the allergist in the audience. And how many would say we need to desensitize the cephalosporin? Okay, most of you haven't voted. There is no option E here. All right. And really what this boils down to is, what is her risk of reacting to cephalosporin given her history, right? Okay. So all of you have heard from your resident or someone else some number out there, cross-reactivity, 5%, 10%, whatever that number is. Most of you have not seen this number probably, and that is, if you take patients who have had non-severe reactions to penicillin, their rate of reacting to cephalosporin is 0.2%. Not very high. Cutaneous reaction to cephalosporin in general population, 1 to 3%. So where does this come from? So this is a study that looked at exactly this clinical scenario. Patients who needed orthopedic surgery, they had penicillin allergy histories, they thought they probably excluded patients with anaphylactic histories of penicillin, and then they gave them cephalosporins, in this case cefazolin, and only one patient may have had a reaction. This is a study that one of our fellows did, Sonak Dalat, looking retrospectively at our county hospital, patients who had penicillin allergy as a label and were administered cephalosporins, first, second, third, fourth generation. 1 out of 606 patients developed eczema, worsening eczema 3 days later. We counted it, and we felt really good about this until we talked with the pharmacists and they said that when the house staff write for cephalosporins, if the story of penicillin allergy is one of anaphylaxis, we don't let them write for that. So again, it's the same caveat. If it's a non-severe reaction to penicillin, your risk of reacting to cephalosporins is indeed low. Now, this is a recent study from the Mayo Clinic where they looked at penicillin skin testing and then seeing, does that change your risk of reacting to cephalosporins? And what they found was most of the patients were not penicillin allergic. And so if you were penicillin skin test negative, your risk was 0.1% to react to cephalosporin. If you were skin test positive, it was 2%. So not huge, but higher. So in our practice parameter, there are several options that we allow clinicians to consider. So if you have a history of penicillin allergy, you need cephalosporin. One thing you could do is penicillin skin testing. The penicillin skin test is negative, you can feel very confident about giving them. But you can also, if the skin test is positive, 98% are going to still tolerate the cephalosporin. One option is just to go ahead and give the cephalosporin directly. I think that's reasonable if the history is non-severe based on the data I've shown you. You can also skin test the cephalosporin, but you still need to do a graded challenge of cephalosporin after that, so that's probably not quite as clean of a story. But there's a lot of different ways that you can handle this. All right, another scenario. Penicillin allergy, and now they need a carbapenem. And what's the issue here? Well, when I was a fellow, we were taught that if you're allergic to penicillin, you had a 50% likelihood of reacting to carbapenems. And this was based on skin testing patients to carbapenems who were penicillin allergic, and 50% of these patients had a positive skin test. What was found was that, when people probably forgot about this literature and were giving it, that, hey, we're not seeing as many reactions. And so if you look at the literature, which is kind of summarized here, if you look at retrospective studies, you see somewhere between 6 and 11% of patients may have had reactions. When you look prospectively at more clearly defined penicillin allergic patients, penicillin skin test positive with histories, who are then administered carbapenems, almost none of them reacted. So it appears to be very low likelihood. So what can you do here? Well, in the prospective studies, what they did first was skin test to the carbapenem first. They only found one patient who was positive and they never challenged them. We rarely do that, and typically what we'll do is give 1/10 of the carbapenem dose, wait an hour, and give the rest. So it's a simple thing that you can do in this scenario. All right, moving on to another scenario. This is the patient who is allergic to sulfa, all right, and you're going to give them some other medication that has sulfa. So what we're really talking about is most likely sulfonamides. And most people who are sulfonamide allergic are due to a sulfonamide antibiotic. And these are different structurally than sulfonamide non-antibiotics that you might find in diuretics, in oral hypoglycemics, et cetera, et cetera. And the question is there cross-reactivity? And so what do we know about sulfonamide antibiotic allergy? Most of these are delayed type reactions, type 4 responses. You can see anaphylaxis, but it's a lot less common. And one population that occurs more frequently, at least it used to, is the HIV population. So this was a study that is now almost a decade old that looked to see, do we see a lot of cross-reactivity? And the answer was, you don't. So if your reaction was to a sulfonamide antibiotic, that you are at slightly increased risk to react to a sulfonamide non-antibiotic, but not as much as if you're allergic to penicillin. Now, what does penicillin have to do with sulfonamides? Nothing. The point is if you're allergic to one drug, you're probably more likely to react to something else, just your propensity to react. And that's what this study showed, not cross-reactive. So it's not an issue, and you can go ahead and prescribe these things. And importantly, when you're labeling patients, label them with the antibiotic allergy or sulfonamide antibiotic. Don't label it with sulfa, and then the patient looks and everything has sulfa in it. All right, let's move on to another case. All right, 61-year-old woman with hypertension. What's the diagnosis? Oh, you want more information? Okay. There. All right. Any clues? So if this is a patient that comes in the emergency room, the top three differential diagnosis is ACE inhibitor angioedema, which is the most common form of angioedema that typically hits the ER in adults. More common in African Americans, and the characteristic feature of ACE angioedema is it's typically neck and above angioedema. Rarely may they have urticaria. Rarely they can have angioedema of the bowel as well. The kicker, and this is where we miss it as internists, is that there's usually a delay. These patients are on the drug for oftentimes almost 2 years before their first onset of angioedema. And that, how can you be taking a drug for a year without causing a problem? Well, that can happen with this. We think this is mainly due to issues with metabolism of bradykinin, and the end result is having increased bradykinin levels, which can cause angioedema. The risk is certainly much less with angiotensin receptor blocking agents, and the treatment is mainly supportive and avoidance. It's a class effect. It's all ACE inhibitors. There's recent information that suggests using bradykinin receptor antagonists may be beneficial acutely. Now, this is a recent study that suggests that in patients who you see have angioedema from an ACE inhibitor, and you stop the ACE inhibitor, that they may continue to still have angioedema episodes. And that's what's shown here. It's a complicated slide, but I just want to focus right here. These are patients who don't have any history of urticaria angioedema before. When you stop the ACE inhibitor, this is the percentage that didn't have any relapses. But then there's some people who have sporadic angioedema and some that were unchanged. And the authors proposed that perhaps the ACE is unmasking their propensity to have angioedema, but that they still may have angioedema thereafter. And this is something that I have also observed, is that you'll see patients who you stop the ACE and the frequency of attacks goes markedly down, but it may not completely go away. And so this is one paper from Italy. It'll be interesting to see if others confirm this observation. All right. This is a case of multiple drug-induced anaphylaxis. 71-year-old woman, E. coli UTI bacteremia, who developed throat itching, swelling, and dysphonia after her 4th dose of IV ciprofloxacin. So she was changed to meropenem and had a similar reaction to the 3rd dose. So we were consulted, and as it turns out, she's had the same multiple drug-induced anaphylaxis, throat closure dysphonia, penicillin, cephalexin, sulfonamides, tetracycline, clarithromycin, on down the line, all the same reaction. So what would we recommend? Should we desensitize her to the ciprofloxacin? Should we desensitize her to meropenem? Should we do a graded challenge to imipenem or something else? So we asked her a few more questions. That's always the least expensive thing to do. As it turns out, she had absolutely no other symptoms with her reactions. All of the symptoms were right in the throat, and no one really witnessed any oral facial swelling. It was just all right here. So what we decided to do was just give her the ciprofloxacin. And 15 minutes later, sure enough, she had her anaphylaxis, throat itching, tightness, dysphonia, exactly the same as her other reactions. The difference this time is we slipped a laryngoscope down and found that instead of laryngeal edema, she was having adduction of her vocal cords. So we told her what we thought was going on, that she had vocal cord dysfunction. We taught her some crude methods for throat relaxation and aborted her anaphylaxis in 5 minutes without giving her any medicine. So this is vocal cord dysfunction, which probably most of you have heard about, typically in the setting of someone who comes in with asthma. But it can also masquerade as anaphylaxis. And what's happening is the vocal cords are coming together when they shouldn't. Classically, this is during inspiration, but it can also occur during expiration. And you end up with a very small opening. So it's very difficult to breathe. And they can have stridorous respirations. So what are the clues for drug-induced vocal cord dysfunction? Almost all patients label themselves, or sometimes are told, that they have anaphylaxis. And when I see a patient who tells me, I have anaphylaxis, especially with the multiple drugs, I usually question that diagnosis. And one of the things I really think about is this. Are the symptoms localized to the throat without any visible swelling? It's very unusual to have isolated laryngeal edema without some visible swelling. Probably the exception are some patients with hereditary angioedema that can swell here without. But most other cases, you'll see some lip swelling, you'll see some tongue swelling, and then they can have here. If this is the only place they're complaining about, this is one of the things that you have to worry about. And then usually there's multiple drugs that are involved. So the treatment oftentimes is with speech therapy. They teach them relaxation methods, and some patients have underlying psychiatric disorders that you need to, but not all. Not all. All right. Let's move on to a drug allergy case to talk about desensitization. This is a woman who developed urticaria, shortness of breath, about a week into a course of clarithromycin for an MAI infection, and the pulmonologist said, you need to be treated for this, so why don't you take a test dose of azithromycin? What was that test dose? 250 milligrams. So after taking that, she got urticaria, shortness of breath, difficulty breathing, went to the emergency room, so hence had anaphylaxis from the test dose. So we were able to come up with some skin testing using some non-irritating concentrations, and indeed, she had positive skin tests to both the clarithromycin Gamish and azithromycin. So the pulmonologist said, you really need to be on something for this MAI infection and macrolide therapy, so what are our choices? Should we challenge her to erythromycin? Should we challenge her to the clarithromycin? Desensitize to clarithromycin? Refer to the university, always a good option. So this brings us to antibiotic desensitization, or drug desensitizations in general. And it's really indicated for patients who you either have proof, either with skin testing, or a very good story that says, yeah, I think this patient really had an allergic reaction, immediate allergic reaction to this drug. And there's no other choices available. This is the drug they need. That's the ideal candidate for desensitization. Most desensitizations are based on penicillin desensitizations. And the prototype is you start with 1/10,000th of the final dose, and you double the dose every 15 minutes. And so you can accomplish this in about 3 to 4 hours. So this is the classic penicillin desensitization protocol. You start with 100 units, then 200, and you double the dose. And after about almost 4 hours, you're up to a therapeutic dose of penicillin. So now, in our situation, there was no clarithromycin desensitization protocol. We looked and we couldn't find one. So what do? You don't panic. You just say, well, if it worked for penicillin, we'll just make one up for clarithromycin. And that's really what most desensitization protocols are like. As allergists, we like to think that we're novel in creating, but it's really not. So basically the same thing, starting 1/10,000th of the dose and doubling dilutions. and it worked very nicely. And this has been done with a lot of different antibiotics, all sorts of different ones, and this is just shown on these different slides. Now, this brings us to the point of different types of desensitizations, or what we refer to in the practice parameters is induction of drug tolerance. Now, what's wrong with desensitization? Well, when we're talking about penicillin desensitization, there's absolutely nothing wrong with it. These penicillin allergic patients are sensitized. They have IgE antibody. After you do the desensitization procedure, you can repeat their testing, and they lose the antibody, so they truly are desensitized. Now, what about someone who, say, for example, is allergic to aspirin, which we're going to talk about in a second? This is not due to IgE antibodies, so they're not really sensitized. So if they're not sensitized before, how can you desensitize them? It doesn't make a lot of sense. The protocols differ greatly depending on the type of reaction in terms of how long it takes. So for penicillin, it may take a few hours. For allopurinol, it may take a month. So, and we all call them the same thing. So what we thought is, these are all ways that you can induce drug tolerance. Some it's based on immunologic properties, some it's based on pharmacologic properties. So there's different subgroups of this, and the protocols are going to differ based on that. All right, which leads us to another case, and this is the direct quote: "Can you desensitize this patient to aspirin right now? She needs a stent urgently." So this is a 47-year-old who has aspirin allergy and needs a stent, and she's got hypertension, diabetes, asthma, hyperlipidemia, GERD, has unstable angina, and they're planning on cathing her. And her story for non-steroidals is she's had multiple episodes of urticaria, lip or tongue swelling within an hour of taking aspirin, naproxen, ibuprofen. Several times it's happened, always the same story. She doesn't have any history of chronic urticaria. So the question is, what kind of allergic reaction to aspirin is this? Because there are multiple types. Is this what we call aspirin-exacerbated respiratory disease? Is this chronic urticaria? Is it acute urticaria? Is it anaphylaxis? Why that's important is because each of these different phenotypes has a different likelihood of cross-reacting reactions to aspirin. So we'll start with one, which is called aspirin-exacerbated respiratory disease. It's a mouthful, but it's a very good description for what these patients have. They have an underlying respiratory disorder like asthma or sinus disease or polyps, and when they take aspirin, they have an exacerbation of their respiratory disorder. Typically, they can't breathe. Okay, so it's usually not a cutaneous reaction. It's bronchospasm. It's dependent on COX-1 inhibition, and COX-2 inhibitors typically are safe. So the natural history of these patients is usually it starts with rhinitis, and then they can develop polyp disease, and sometimes asthma becomes later, and then their aspirin hypersensitivity later on. Now, it doesn't have to happen in that order, but this is the classic description. Now, these patients, if they take any strong COX-1 inhibitors, they'll react to all of them. So patients with respiratory reactions, asthma, and when they take aspirin, they react. It's not aspirin allergy, it's virtually all nonsteroidals. Weak inhibitors like acetaminophen are generally well tolerated, and then selective COX-2 inhibitors are safe. So if you look at patients with different phenotypes, those who have kind of reactions to all nonsteroidals, like we talked about, the AERD group is in that group. Patients who have chronic urticaria, and when they take nonsteroidals, they have urticaria, they will typically react to all of them. And then there's some patients who don't have chronic urticaria, but have urticaria when they take multiple nonsteroidals, they will react. And that's what our patient fit into. Now, there are some patients that are drug-specific reactors. Patients who have had anaphylaxis to nonsteroidals usually are drug-specific. They'll tolerate other nonsteroidals. What's confusing is they're going back that if you just have urticaria angioedema, you may be drug-specific reaction. You may cross-react. That's the hardest one to figure out because it can go either way. So what to do for this patient? Well, as it turns out, there's multiple protocols that do this rapid, what's called a aspirin desensitization or graded challenge, and it seems to work. You look at all the protocols, they're all about the same. unless you have chronic urticaria where it doesn't work so well. Now the question is, are we really inducing drug tolerance, or were they really not allergic and we were just doing a fancy graded challenge? Nobody knows the answer to that, but you can do this, and at the end of the day, you can get the person on aspirin. So this is one of the protocols. It's stepped up pretty quickly, and depending on how much you need, 81 or 325 milligrams. All right. So what did we do? Turns out her cath was negative, but they said, yeah, she needs some low-dose aspirin anyway because of all these risk factors. And so she underwent this protocol, and she did fine with it. All right. So these are some of the take-home points that I'd like to leave you with. First of all is these dress reactions are often unrecognized. It's something I think as internists that you need to think about. Anyone who has fever and a cutaneous reaction where you're working on a drug, get some other laboratories on them. If you see elevated liver function tests, think about this. Penicillin allergic subjects with non-severe histories typically tolerate cephalosporins. ACE angioedema can be delayed, so don't forget about that in your patients. Isolated throat swelling may really be vocal cord dysfunction. Antibiotic desensitizations, we can certainly use them for patients who really need it, especially if it's IgE mediated. Patients with aspirin-exacerbated respiratory disease need to avoid all COX-1 inhibitors, not just aspirin. And then patients with various aspirin reactions may be able to tolerate aspirin via either graded challenges or with desensitization protocols. And with that, I will end and be happy to take any questions. Thank you.
Thank you very much. So we have 5 minutes exactly for questions before the slides go up and shut us out. So, Dr. Wadham.
Sometimes we see patients who require root diuretics and have inability to take furosemide, usually because of skin reactions. Do you have any tricks for managing those folks?
So is this more kind of like they take the medication, it's more of a delayed cutaneous reaction? So I think there's a couple approaches that I use in these patients, and it's just a very similar thing that I would say with statins too, is patients may have these kind of delayed reactions with that. And what we'll usually do is kind of do one of these prolonged graded challenges. Well, we'll start them with a homeopathic dose of whatever the agent, whatever we can break it down into an eighth or something very tiny. And we'll have them take that for maybe a week or so and then gradually work up to that. Now, what are we doing with that? Are we doing anything immunologically? Maybe, maybe not. One thing I think psychologically it helps because you're telling the patient, I'm starting on this smaller dose and it's a little bit more reassuring. And then it also allows you the time, if you're going to have a reaction, it's going to be less severe. And then you can work your way through different agents, and usually you can find something doing it that way. And I think it's not something they need to do in the clinic because, you know, these reactions take a while, but you can do it that way. For patients who have lots of reactions that are not as clearly documented, then we'll use placebo to sort that out. And we'll give people a few weeks of placebo reactions, and then they'll record on their diary what they all had. And if it turns out, you know, the first few weeks of placebo, they're having all the same symptoms, well, then we'll go ahead with the drug, and then we unmask it at the end. And that's a very useful thing. But if it's a real something that you can see, and a lot of times I will also say, I want to see the rash. And sometimes they'll come in describing what sounds horrible on the phone. You look and you can't even see anything. And it's always, oh, the rash is just beneath my skin. Well, okay, then we don't need to worry about that. Yes?
Some of the stats, you know, were surprisingly low numbers for things. I'm just curious, you know, there's so many people with a history of, you know, I had a little bit of a rash with penicillin. I mean, are there studies looking at, you know, if you re-expose those people without going through a large, you know, graded challenge or desensitization or whatever, just how many people that had a rash with penicillin end up being able to tolerate it, you know, down the road?
Right, right. So if the statistics for patients with a label of penicillin allergy, what we know is that 90% when you skin test and challenge them with penicillin can tolerate penicillin.
Your conference is scheduled to end in 2 minutes.
The 10% are those patients who are skin test positive to penicillin. And that's based on a little older literature. Now the rate of penicillin positivity on such patients is probably 5% or less. What's a little less clear is if you have, one of these, I don't know what happened, and you have a positive penicillin skin test, what's the real likelihood that giving them penicillin, even in the face of a positive skin test, means anything? There's only been a few studies, and it does suggest that it's still a very low likelihood. But as allergists, when we see positive skin tests, we're kind of nervous about giving the drug. But that's, I'd say off the bat, you could say, and time is also important. So at 5 years, 50% of penicillin allergic patients lose IgE, and at 10 years, it's about 85%. So that can be also helpful in terms of what is that risk of these patients.
So you can put on the side about ACE and hereditary angioedema as an absolute contraindication. Is that true for ARBs as well in that setting?
Yeah, so there's not a lot of information on that. The group in Italy has kind of commented in some of their paper. They have very large populations of hereditary angioedema, and they have commented that they can typically get by with using angiotensin receptor blocking agents in patients with hereditary angioedema. But there's not really good data for that. I wonder if a lot of the ARB data with angioedema... I'd like to answer that, but I can't.
Waiting for a long time.
I wonder if a lot of the ARB angioedema is related to this phenomena of when you stop the ACE that they continue to have angioedema. And maybe it has nothing to do with the drug at all, that somehow that switch has been turned on and now they're just going to have angioedema anyway. So I think the answer is not clear, but it seems like if there's good reasons, it's not a contraindication to use an ARB in hereditary angioedema.
Well, as we've been told, the conference is over. Really, David, I'd like to thank you for covering pretty much everything anyone would want to know about drug allergy.